Hormone therapy for postmenopausal women. My name is Ocampo. Definition: hormone therapy is a highly effective for management of vasomotor symptoms in postmenopausal women. Vaginal estrogen is used for genitourinary symptoms only. Hormone therapy is not recommended for primary or secondary prevention of coronary heart disease or dementia. Several non-hormone therapies are also effective for vasomotor symptoms.
Katie on September 10th. See you later. Hi, everyone. As a woman of a certain age, I find myself increasingly drawn to articles about the M word, that's right, menopause, particularly a recent one that said calcium and vitamin D supplements are not that beneficial for postmenopausal women. Well, given the fact that there are so many ads purporting the health benefits of these supplements, I decided I needed to find out more. So I went to Dr. Becky Brightman, an OBGYN here in New York, to find out.
I think the study drives home the point that we've known for a long time, is that estrogen really plays a role in terms of helping to deposit calcium into bone. So after menopause, women stop making estrogen, and as a result, they stop making bone, and their bone mass really rapidly starts to decline.
What if you're on hormone replacement therapy or getting estrogen from another source? Does the calcium and vitamin D work better then?
Oh, absolutely. And the closer a woman is to actually going through menopause, the more efficiently she will start to reabsorb the calcium. And vitamin D actually helps in the reabsorption of calcium.
So the keys to keeping your bones strong are exercise and a calcium-rich diet when your body's producing estrogen at an early age. So you're in good shape when menopause starts, right?
Absolutely.
So what kind of exercise, Becky?
Exercises that really build up, particularly the upper body, anything that involves the use of weights, push-ups, yoga.
You can also use small hand weights if you
Absolutely.
wanted. Oh, I'm sorry. Which way to the hand weights? Okay, sorry.
Oh my goodness. But I think that it's really, really important. And also calcium really needs to be part of a young woman's routine. You know, whether or not they get it through 3 dairy servings.
And vegetables,
And
right?
vegetables,
Like
broccoli, kale, other green leafy vegetables. There are many ways in which one can have adequate calcium and help maximize their bone mass before they go into menopause and start a decline.
And by the way, Dr. Brightman recommends a baseline bone density test for women over 50 or anyone who happens to be going through menopause. Insurance plans do provide coverage for this, but it may vary, so check with your provider and, of course, talk with your doctor about all of these things. I'll see you next week, and, of course, for the debut of my new talk show.
Application in medicines. One younger than 60 years of age or within 10 years after the onset of menopause who have symptoms menopausal hot flash or night sweat are most likely to benefit from hormone therapy. For women with early menopause without contraindications, hormone therapy is a recommendation until at least the average age of natural menopause. Observational studies suggest that the risk from thromboembolies and stroke is lower with transdermal therapy than with oral hormone therapy.
Menopause really marks the end of the reproductive life of a female, where the ovaries start to shrink and you deplete estrogen and progesterone. So it would seem straightforward to then replace these two hormones, but it gets more complicated than that. Some risk factors for hormone replacement therapy really became apparent in a study done, which started in the early 90s, that looked at long-term hormone replacement therapy. This was done by the Women's Health Initiative and lasted about 15 years. What it showed was that hormone replacement therapy actually increased slightly the amount of blood clots and strokes that occurred in people. And if you took it for a prolonged period of time, it increased your chances of breast cancer. The one positive came out of it was that it prevented, estrogen alone at least, prevented against osteoporosis. So most commonly today, hormone replacement therapy would be prescribed by clinicians to alleviate some of the symptoms of menopause, things like night sweats and hot flashes. But prolonged use really doesn't really do a benefit any longer. So before you take hormone replacement therapy, some of the risk factors you should consider is whether you're going to take estrogen alone or with progestin, which is a synthetic progesterone, what age you enter menopause, what's your current age, and then probably the most important is your family history. Do you have a family history of cancer? Do you have a family history of cardiovascular problems? And then, obviously you'd consult with a physician for all of this before you make that decision.
Pro and cons. Pro. Progestin are used in women with an intact uterus to protect against uterine cancer. Observational study has suggested that the risk of BTE and possibility breast cancer and negative effects on mood and lipid levels are lower with micronized progesterone than with progestins.
Hormone therapy is often used to ease symptoms like hot flashes in postmenopausal women, but this practice may have another benefit. I'm Shelby Cullinan with your latest health news. A new study found that women who continuously took estrogen plus progestin after menopause had a lower risk of developing endometrial cancer, or cancer that starts in the inner lining of the uterus. Estrogen and progestin are two female sex hormones. After menopause, women's bodies produce less of these hormones. This can cause symptoms like hot flashes and increase the risk for osteoporosis. Speak to your doctor about whether hormone therapy is right for you.
Cons. Controversy exists regarding how long hormone therapies can be safely used and when it should be discontinued. Vasomotor symptoms return in approximately 50% of women after discontinuation. Data are lacking for directly compare the effect of stopping cold turkey with thought of stopping over 3 to 6 months for recurrent bothersome hot flashes. Clinical experience supports a gradual taper over 6 months to 1 year.
Nicole Ireland. Blanca Tovar Verma first came to talk to her family doctor about menopause a year ago.
I was one of those women who thought, I can do it on my own.
But her hot flashes and night sweats became so intense, she barely got 3 hours of sleep a night. She had a busy career and loved to travel, but depression and desperation set in as she felt her normally energetic self slipping away.
One day I was thinking, who's this person? This is not the person I know. This is not the Blanca I know.
6 months ago, she and Dr. Iris Gorfinkel decided to try hormone replacement therapy, even though breast cancer was a potential risk.
The question ultimately is, how bad are those symptoms? And do those symptoms impact enough negatively in her life to warrant hormonal replacement therapy?
Hold your breath. Research findings on hormone replacement therapy and breast cancer have been inconsistent over the decades. So Oxford University scientists combed through years of studies involving more than 100,000 postmenopausal women who had developed breast cancer. Their findings, published in the Lancet Medical Journal, say the formulation of hormones women take matters. About 1 in 50 women who take estrogen and progesterone for 5 years will get breast cancer. That number decreases to 1 in 70 if they take progesterone less often, and if they take estrogen only, the risk decreases to 1 in 200. Another critical finding, how long women take hormone replacement therapy for also makes a difference.
Increasing duration of use was also associated with a significantly increasing risk of breast cancer. So limiting use to under 5 years of either formulation would be ideal.
Joanne Kotsopoulos wrote a commentary on the Lancet study.
Clinicians and patients have to work together to really have a frank discussion about their symptoms as they enter menopause.
For Dr. Iris Gorfinkel, that's the key.
It's not a slam dunk, one answer for everybody. The answer should be a very individualized response.
That worked for Blanca Tovar Verma. She's back to her normal self, confident they made the right decision for her. Nicole Ireland, CBC News, Toronto.
Issue applicating in Ecuador. Hormone therapy is an acceptable option for the relatively young up to age 59 or within 10 years of menopause and healthy women who are bothered by moderate and to severe menopausal symptoms. Individualization is the key in the decision to use hormone therapy.
After the age of 30, bone resorption will slightly exceed formation and bone mass begins to diminish. In women, this can become even more of an issue following the onset of the menopause, where declining estrogen levels further increase the rate of bone resorption. Osteoclasts are regulated by various signaling molecules, including rank ligand. Rank ligand promotes the differentiation, activation, and survival of osteoclasts via an interaction with its receptor, rank. Once activated, osteoclasts resorb bone. However, the hormone estrogen is thought to repress rank ligand signaling. Downregulation of rank ligand expression leads to decreased activation of rank and a subsequent decrease in osteoclast-mediated bone resorption. Estrogen has also been shown to stimulate the expression of osteoprotegerin, which inhibits the activity of rank ligand by preventing it from interacting with its receptor. Following the onset of menopause, estrogen levels start to decline. This can lead to increased rank ligand production, which is associated with increased bone resorption in postmenopausal women. Increased bone resorption after the menopause leads to the accelerated loss of bone mineral density, which can result in the more severe condition of postmenopausal osteoporosis, in which the skeleton becomes increasingly susceptible to fracture. Vertebral collapse is often secondary to osteoporosis and is more prevalent in women. In osteoporosis, the thickness of both cortical and trabecular bone decreases over time, suggesting that both of these structures play a role in the development of vertebral fractures. These events, such as fragility fractures of the hip or vertebrae, may contribute to the painful and debilitating symptoms that can arise from osteoporosis. Several other factors influence the rate of bone mineral loss. These include genetic factors, lifestyle factors, and the use of certain medical therapies, all of which are thought to play a role in the development of osteoporosis.
Conclusion: menopausal hormone therapy provides relief for hot flashes and night sweats, reduce bone loss and risk of fractures, and address genitourinary syndrome of menopause. Observational studies have suggested reduced risk of cardiovascular disease and dementia with postmenopausal hormone therapy. Thank you.